Hello. Okay. Thanks, Elaine. So Leslie does the presentation and then we've got the questions and then Andrew reads these questions. Okay, welcome everyone. We're good to go, are we? Yeah. Can everybody hear me? Am I clear? Oh, I hear. Ooh. Yep, sounds like the mic is working. So thank you very much for having us along today. My name is Marie Todd. I'm Minister for Social Care, Mental Wellbeing and Sport. And this is Caroline Lamb.
Yeah, and I'm Director General for Health and Social Care at Scottish Government and Chief Executive of NHS Scotland.
So we're delighted to be here to conduct this review in person after so many years apart. It's a first time experience for me because I wasn't a junior health minister before the pandemic. Although I've participated in annual reviews over the course of the pandemic, they've been a slimmed down version and virtual. But it's really lovely to see you. We spent the morning with some of your staff and with some patients. We've heard a lot about some of the challenges and some of the really positive stories that are coming from NHS Ayrshire and Arran. It's part of the process of holding boards to account because very large sums of public money go into our NHS. So, as I say, this annual review is part of that process of scrutiny about how money is spent. And it's also a chance for us to hear exactly how things are going, what challenges and what priorities you have, to understand better how things have gone over the course of the pandemic, which has been one of the toughest times we faced as an NHS, but also to think about how things might be changing looking forward. The board chair will present on national and local priority areas. We'll spend a few minutes summarising the extraordinary pandemic response from NHS staff in the area before moving to themes of resilience, recovery and renewal in line with national and local priorities. After that, I'm going to chair a Q&A session where the questions are clearly for the board. I'll ask the Chair and Chief Executive to respond. I should say at the outset it's not appropriate to answer questions that are patient-specific in this public forum, but these can be followed up by officials of the board following the review. There isn't an opportunity for online attendees to ask a question in real time, so the board have offered the opportunity to lodge a written question in advance, and we have a number of those. I think it says in my briefing 2, but I think we now have 3, so I'll make sure that those questions are posed first. And then there will be, following this session, there will be a private session with the board leadership following this meeting, and that session will involve a more detailed discussion about local performance. And there will be a ministerial letter as a follow-up after that to make sure that we're all clear on what was discussed and what needs to happen moving forward, and that will be published on the board's website. So, Leslie Bowie is the board chief executive, and I am going to hand over to Leslie to give our presentation.
Thank you. So I'm the board chair, Claire's the chief executive, that's okay. A couple of housekeeping matters just before we start. There are no fire alarm schedules for this afternoon, but if one alarm sounds, then the exits are clearly marked, and just follow somebody like Crawford who'll know where he's going. A recording has been made of today's session and will be put up on our website as soon as it's made available to us. And also I'm informed that there are evaluation forums should anyone wish to fill out an evaluation form after the session. Minister, I'm pleased to welcome you and welcome Caroline to Ayrshire and Arran and to University Hospital Ayr, and a warm welcome to everyone who's joined us here today in person or online. We're here, as the Minister said, to look at our achievements and challenges over the last 18 months or so, filled with successes as well as areas where we know we need to improve and do better for the citizens of Ayrshire and Arran. Can we go to the next slide, please? Thank you. I don't want to say a lot about this slide. You can see, though, that although testing requirements ended in April 22, COVID was clearly still prevalent in communities, and that can be evidenced in the bottom chart when you see the peaks of inpatient admissions to our hospitals. And we had a peak in April 22, and that slide continues with some peaks right through to March this year. So it's never gone away, and as few as in this room can attest, in recent weeks it's still very much on the go. Next slide, please, Elaine. As this is our first public annual review since before the pandemic, it is an opportune time to reflect on everyone's response. The pandemic has undoubtedly been the single greatest challenge we've faced in recent times, and I want to acknowledge the hard work and commitment of our teams across health and social care. To say thank you to each and every person, every member of staff who worked and who continues to work tirelessly to deliver the highest standard of care to the people who use our services. I'd also like to thank our communities for their immense and concerted efforts, demonstrating the very best in terms of resilience and community activism, by providing help and support to those that are more isolated and vulnerable within our communities, ensuring they remain connected and safe during the pandemic times. Next slide, please. Services across the whole health and care system remain under extreme pressure, and we recognise that the pandemic has resulted in significant backlogs of patients waiting assessment and treatment for planned care. In addition, patients are presenting to our emergency departments and combined assessment units with more complex needs, resulting in extended lengths of stay and higher occupancy rates in the hospitals. This, combined with higher numbers of patients delayed in their transfer of care from our hospitals, has an impact on the flow through the hospital and on the resulting waits on our emergency departments. In primary care, our primary care colleagues have seen a significant increase in activity since before the pandemic. With activity in general practice previously around 190,000 patient contacts per month, now over 250,000 contacts per month, a 31% increase in all in that same Monday to Friday timeframe. Such high patient demand can at times outweigh the clinical capacity, so it is important and it's often needed that patient triage, it's important and patient triage is often required to ensure that sicker patients are prioritised. Primary care team and clinical directors engage regularly with practices to ensure that we identify issues early and offer practical support. And I mentioned delayed transfers of care in hospital, but that is only part of the story. There are high numbers of people awaiting a package of care in our communities, and this creates further risk of people falling into crisis and potentially turning up in our hospitals. Next slide, please. All services have now remobilised and are working towards a new waiting time targets, as well as prioritising patients deemed to have a high clinical urgency. And we recognise there's a physical and mental consequence in having to wait a long period to be treated. And addressing long waits is a key focus for us, and that means that some patients will be offered an appointment out with our local health board area in order to get their treatment more quickly. There's still a lot of work to do, but we are making progress. Our overall waiting list for inpatients and day case treatments are starting to fall, and those patients waiting less than 12 weeks for a new outpatient appointment is remaining level. But we do, of course, have waits that are much longer than this. Some actions we've taken in outpatients include a waiting list validation process. We also have mutual aid capacity in place for diabetes and endocrinology, and for neurology with NHS Forth Valley. Mutual aid arrangements are also now confirmed with NHS Grampian for gastroenterology. We have insourcing contracts in place, providing additional outpatient capacity for a number of specialties: respiratory, dermatology, neurology, ophthalmology, gastroenterology, and rheumatology. For inpatients in day cases, the day case recovery space at University Hospital Cross House continues to be a significant constraint for us, but some recent estate work has increased recovery spaces to 17, and this is supporting a slightly higher patient throughput each day. Workforce shortages in theatre nursing and in anaesthetics are also limiting the number of theatre lists which can run each day. And although there's been some improvement in recent months, this continues to also be a significant constraint. Theatre capacity has been closely managed via a weekly scheduling meeting chaired by the clinical director, and theatre utilisation is closely monitored through weekly operational meetings. And a particular focus for us in 23-24 is reducing the gap time between patients. Next slide. Diagnostic services were also significantly impacted during the pandemic by social distancing requirements and by national infection control protocols. We've made significant progress in this area, with our waiting list for endoscopy now at lower levels than pre-pandemic. And the introduction of the mobile MRI scanners and additional CT pod have resulted in less people waiting for these scans than before the pandemic. We do have a challenge in ultrasound services. This is impacting our overall imaging performance, with 64% of patients waiting less than 6 weeks against the 100% target. Looking forward at Imaging First, the mobile MRI scanner will remain in situ until 31st of March 2024, and it's playing a big part in reducing the waiting list. However, the Scottish Government have intimated the funding will not be carried on beyond March 2024, and this is a significant concern for us, the loss of this capacity. With regard to the CT pod at Ayrshire Central Hospital, staffing for the pod will now be funded on a recurring basis, so that is good news. There's a plan for development of a diagnostic hub at Ayrshire Central Hospital, incorporating the CT pod and hopefully a new static MRI scanner, but this will require identification of capital funding. And in ultrasound, demand significantly outstrips capacity. The service has recently made 2 new appointments and has also had additional funding for 2 new trainee posts. This is considered a positive step in addressing workforce sustainability, although it will take 12 to 18 months for it to be seen in the waiting list. In addition, 5 international radiographers have started in post, with a further 5 preferred candidates due to start very soon. In endoscopy, the recovery space for endoscopy at University Cross House remains restricted due to the placement of the extended intensive care unit. A 4th endoscopy room has just been created here in Ayr, and this will help. In cancer, over 95% of patients are starting their treatment within 31 days of a decision being taken to treat. And in July this year, all patients started their treatment within 31 days of a decision being taken to treat. We are not currently achieving the targets for patients with suspicion of cancer to start their treatment within 62 days, and in July we achieved this for 81.3% of our patients. Recovering and improving cancer performance and further developing and improving the cancer service is a high priority for us. Continued focus on addressing diagnostic delays form part of our cancer plan, particularly the actions I've just mentioned around imaging and endoscopy capacity. We have actions underway to address the pathology backlog and capacity shortfall, including local appointments and outsourcing. And the Rapid Cancer Diagnosis Service has received 639 referrals up to the end of July of this year, and we hope to be able to secure funding to continue this pathway beyond April 2024. Next slide, please, Elaine. Excuse me. Call before convey was implemented in 22-23, and this involves ambulance service crews receiving decision support from clinicians and exploring alternatives from patients before conveying to hospital. Locally, our aim is that at least 85% of patients who contact our Ayrshire Urgent Care Service will not require attendance at the front door and will receive alternative care at the right place and at the right time. If I look at ED, services across the whole health and care system remain under extreme pressure during 22-23. Patients presented with complex acute needs, and this, combined with high levels of delayed discharge, staff absence, and continued infection control measures during peak periods of flu and COVID, added to the complexity of managing patient flow, impacting our 4-hour ED performance and also impacting ambulance turnaround times. And at times of peak pressure, there have been longer waits for patients arriving by ambulance than we would want. We aim to bring our turnaround time in line with the Scottish figure, and we have managed to achieve this at several points since the start of April this year. However, we have seen an increase in turnaround times in recent weeks, and we continue to work collectively with our partners to address this. Next slide. No, sorry. The Strategic Planning and Operational Group have agreed a revised urgent and unscheduled care improvement plan, which has 5 work streams. Work stream 1 is focused around Ayrshire Urgent Care Services and includes call before convey, enhanced access for care homes, alternative navigation to community mental health services for urgent mental health patients, the expanded provision of a rapid respiratory response pathway, and further development of the community pharmacy pathway. Workstream 2, it includes hospital at home. Currently 16 virtual beds, expanding to 24 virtual beds by the end of this financial year. This service now supports all in-hours nursing home patient referrals. It can deliver an IV antimicrobial service and can also take direct referrals from Scottish Ambulance Service. Front door reconfiguration work, we had a 12-week focus programme that saw a reduction of 12-hour waits in ED and a reduction in ambulance turnaround times. And the rapid assessment and care area, which is situated within University Hospital Cross House, is achieving a discharge rate of over 80%. Workstream 3 is the implementation of multidisciplinary team board rounds across both acute sites using the discharge without delay principles. Workstream 4 is focused on South Ayrshire's care at home provision and review of the care needs within South Ayrshire. And Workstream 5 is the paediatric workstream. It's in the very early stages, only recently been added, and goals are still to be set for that. Next slide, please, Elaine. Mental health performance. This is July data, and as you can see, we're meeting the target for all 3 mental health measures. In CAMHS, our year-to-date average is 98%, but maintaining the 18-week time standard will be a challenge going forward. We expect to see an increase in referrals following full implementation of the CAMHS specification from August. And this is on top of a doubling in referrals that we've had over the last year. Recruitment is challenging in this area, particularly around psychiatry, nursing and psychology. But the service continues to look at the skill mix in the team, and they're recruiting more allied health professionals and play therapists to bring a different dimension to the team. Also, CAMHS had a contract with external providers to help young people in the neuro waiting list get an assessment appointment sooner. The contract came to an end in June, and the new contract is not expected to be in place before October. So we'll just have to keep an eye on that one. In psychological therapies, in a very competitive workforce context, we have successfully appointed to our full Scottish Government psychological therapies funding allocation. And to date, the additional funding has enabled us to develop our service provision to addictions, staff wellbeing, pain management, weight management, adult inpatient, infant mental health, eating disorders, and trauma neurorehabilitation beds. In drug and alcohol treatment, we are consistently above our target of 90%. All 3 local authority areas are implementing the MAP plans, and drug deaths, of course, remains an area of concern for us in Ayrshire. Next slide, please. As a board, we recognise that recovery will require transformation, and securing transformation when the pace and demand for service is high is not simple. However, working together as a whole system, we are committed to reduce health inequalities, and with our anchor organisation status and our ambitions for wealth creation, we want to make Ayrshire a place of choice, to establish a future that retains and nurtures its local communities for the benefit of all citizens. We will continue to work collaboratively with our health and social care partners and our wider community planning partners to improve planning and investment in our communities, to optimise population health, not only through better provision of health and care services, but through wider economic benefit, regeneration and growth in our communities. In innovation, a recent example is the introduction of the robot-assisted surgery at University Hospital Cross House. And I'm proud to say that our teams completed their first surgery in July. Okay. Last winter was exceptionally challenging, and patient safety remained the main consideration in all decisions taken around service delivery in extremist circumstances. Planning for this winter started with a debrief questionnaire on last winter. What went well, what didn't go well, and what solutions have been identified to help with preparedness for the upcoming winter. And the learning is what's shaping our winter planning for this year. We do have local modelling enabling us to forecast the numbers of beds that will be occupied both by elective and emergency inpatients, and taking into account the effects of delayed transfers and the peaks of flu and COVID. Recognising and managing demand and capacity requires a whole system approach, and we work collaboratively around the development of continuity plans with all of our partners. The plans aim to help mitigate the risk of further escalation and ensure an appropriate response from key staff and key partners to contribute to a reduction in our escalation status, as well as maintaining business continuity, high standards of patient safety and patient experience, and to support staff resilience in challenging circumstances. In the immediate term, our priorities are to focus on system safety and service resilience to ensure we're the safest hospitals possible. To ensure progress in delivering against our Caring for Ayrshire strategy, we have agreed 3 corporate priorities. the delivery of a sustainable financial future, redefining bed-based care, and digital reform. Digital reform, supporting clinical and non-clinical reform by enabling new ways of working, reducing duplication and reduce clinical risks. We will ensure that our recent learning is captured, inclusive of the positive and negative features of the pandemic, and this learning will support our workforce to deliver care closer to home. Redefining bed-based care is a whole system piece of work, and over the next 3 years, our ambition is to systematically plan to redefine our bed base in the acute sector in preference for right-sized services, including best-based care options in the community. This will allow a redistribution of workforce across the acute sector, which will support safer staffing models, reduce risks of harm to patients, and reduce high-cost workforce investment, contributing to the financial stability of our acute hospitals. Digital reform and a system-wide reprovision of bed-based care will support NHS Ayrshire and Arran in the journey towards a more sustainable financial future. Next slide, please. Our shared ambition, this is my favourite slide, our shared ambition, as captured in our Caring for Ayrshire strategy, is to develop and deliver on a whole system programme of work to ensure access to care is available for every person at the time they need it. This diagram illustrates how, as a system, we are working together to secure high-quality primary and community care services, delivering care closer to home, and, when required, ensuring that our patients have access to specialist care in our local hospitals and through our national service networks. Next slide, please. Bit of a whistle-stop tour, Minister. Thanks, everyone, for listening, and I'll hand back to you. Thank you.
Thank you very much. It was a whistle-stop tour, but I think it shows you the real breadth of effort going on across the board to improve systems and to continue to improve systems at a time when we're still feeling pretty significant pressure from the COVID pandemic. I always say about the pandemic, we've just gone into a different phase. We haven't come out the other side quite yet. And I think that everybody in this room will be aware of that at this moment in time. We're about to start our winter vaccine programme. Because of, more urgent than ever because of some of the concern about new variants. So impressive to see the range of efforts going on across the board. And I'm very grateful for that whistle-stop tour. I don't know if there's anything you want to say, or shall we just go into public questions? So the 2 questions that were received in advance, I'll start with the first one. The first question raises concerns at service provision in University Hospital Ayr, specifically the loss of critical care beds, limited services, especially in gastroenterology and diabetes care, with a lack of arrangements to transfer care to another consultant following a recent retrial. It says retrial. I'm hoping that's retrial. I guess everyone in attendance will appreciate that patient safety is of paramount concern, and I know that the board's interim plans to transfer the 3 ICU beds to Crosshouse Hospital are in place to ensure the appropriate medical cover. I'm also conscious that the board's has assured us that all feasible options will continue to be explored to maintain the beds at Ayr Hospital. And in terms of the wider point, please be absolutely assured that both the Scottish Government and NHS Ayrshire and Arran are completely committed to the provision of high-quality services on the Ayr Hospital site, including the A&E department and its support services. So I'm going to hand over to the board to comment on the question, including the specific points around the gastroenterology and diabetes and around the arrangements to support the continuity of patient care with changes in staffing.
Thank you very much. Thank you very much, Minister. Good afternoon, Claire Bedden for NHS Ayrshire and Arran. So you'll have heard in the press that we are constantly challenged with concerns that Ayr Hospital is being wound down, that areas of it are closing. We can categorically confirm there are no plans to do that. We need both our hospitals, we need all of our estate with the current demand for services, and our only balancing metric at the moment is safety. And maintaining 2 hospital sites and ensuring their safety is the point of discussion with our clinical teams. And actually all of the services that you've mentioned are holding significant workforce constraints. And it's those workforce constraints that are driving how do we ensure both sites are safe. So the critical care team did a tremendous job, as discussed earlier, throughout COVID, and expanded into areas at Crosshouse Hospital. None of it quite fit for purpose, but they've made best of the estate that we have. And we require critical care at both hospitals. So the critical care leadership team work together on how do we maintain the level of service at both sites. The level 3 care, the highest level of care, the contingency to get us through this workforce period, and particularly this winter, is that the highest levels of care would be provided from Crosshouse Hospital. So if you're in organ failure, if you require mechanical ventilation for an extended period of time, your care needs would be best and most consistently cared for at Crosshouse Hospital. So the medical teams would determine, if you're in a planned care, that if you were a local resident and they were at risk, then you would go to Crosshouse. There is critical care at Ayr. It's not at the highest level, but for the majority of patients who would go through surgery, the level of care that we would be providing, the one-to-one care within critical care, will still be provided at Ayr Hospital. We're committed to working through our workforce models to recruit in an ideal world, and Crawford, our medical director in the audience, is working constantly to draw medics into the area. But we're not on our own. This is a UK-wide challenge, as specialty medicine and training has changed, and critical care and anaesthetics are specialty teams, and we need to create an anaesthetic team for the theatres and a dedicated critical care team for our critical care units. So please be assured we need both hospitals. We will do everything we can to balance those services across both sites, because we need both sites. We need all the theatres that we've got, so full recruitment is important. But what is in the media at the moment are the contingencies that we need to put in place to ensure that people are safe. If we were to continue with the diabetes and recruitment, actually that's in exactly the same position. We want to be able to provide acute services on both sites, but if you require specialist interventions, then you might need to go to Crosshouse Hospital. We treat general medical throughout Ayrshire, and we have teams obviously making the most of technology where support can be is available. But if you require to be seen by a specific consultant, then there might be plans that mean that you will be directed to Crosshouse Hospital. But there are no plans to withdraw specialty services from Ayr Hospital. I hope that covers really the majority of it, but I appreciate that I think we must get a call at least twice a week to try to reaffirm that the Ayr Hospital site is secure in our system, and I'd like to take the opportunity that actually neither of our hospitals is large enough to lose the other. We require the capacity that we've got in order to serve the population, and there are no plans to build something different in the foreseeable future, so all of our efforts around making the most of our current estate. Thank you.
Thank you very much. That's really helpful to hear, and it certainly was came up in the discussion this morning, particularly with the patients, but also I suppose your presentation illustrated some of the changes that are afoot and the way that care looks different, and that some of the things that used to only be available in hospitals are now happening at home. So that's, we're at a time of flux, if we ever weren't in a time of flux in the NHS, but we're definitely at during a period of change at the moment. The second question lodged in advance asked, what is the national approach to reduce waiting times for planned care? So from a government perspective, we're absolutely committed to providing year-on-year reductions through our 1 billion NHS recovery plan and our network of national treatment services, which will significantly increase capacity. Nationally, we've already seen a significant reduction in the very longest waits since targets were announced last July, with 80% of outpatient specialties and 60% of inpatient day case specialties now having fewer than 10 patients waiting more than 2 years, so that's significant progress. In addition, waits of over 78 weeks have reduced by 48% for new outpatients since June 22. So we recognise that challenges do remain and there are still unacceptable waits in some specialties, but we're committed to delivering sustained improvements and year-on-year reductions through service redesign and enhancing regional and national networking. So this is, I'm conscious of review of NHS Ayrshire and Arran, so I will let you update folk with the changes that are afoot and the local performance times here.
Thank you. You'll have caught in our presentation with Leslie that we have taken advantage of mutual aid, insourcing, outsourcing, wherever we have shortfalls. And having spoken earlier about diabetes, neurology, gastroenterology, there are services where our workforce is shy of the demand. So at the current time, our annual delivery plan committed that we would be at least 85% of where we were in pre-pandemic levels. Our theatres are almost at that level, and whilst there are many other areas of our service that have seen workforce gains, there have been very few workforce gains within the theatre team. So the fact that they are working to plan is a credit to the teams. We have specialty shortfalls as described in detail by Leslie, and we work very closely with system partners and have a dedicated team working on our planned care recovery trajectories. And wherever it's possible to get people on a shortening waiting list, then we make that offer to them. Some patients choose not to, that they would prefer to wait, in which case they are retained on the list. But where we can provide an alternative, then we will make that available to teams locally. There aren't many health boards with a lot of capacity. That suggests that significant numbers of patients will be relocated. We expect to treat the majority of our community locally, but it's important that wherever there are options, and occasionally we're contacted by patients seeking alternatives, of course we would work with them to facilitate them onto any available list. We have also our partnerships with the Jubilee, the national provision with regards to the elective care programme, and we have exceeded our allocations in support within those facilities. I think that I'd like to take the opportunity to reassure citizens that the scrutiny that goes into patients waiting on the lists are significant. Throughout the pandemic, our clinical teams risk assessed and validated thousands of patients on those waiting lists. Some patients have taken treatment in other areas. Some patients have been referred back to their primary care practitioners, and others have been brought forward into outpatients. But it is a constant process. Leslie very kindly shared earlier that our waits for outpatients are plateauing, and that's really the amount of activity coming in is currently matching the amount of activity we're working through. So it can feel a little as if we're not making progress through our operational teams. And as shared earlier, we're actually working through a lot. And you'll see that in the reductions in our average waiting times and those milestones of reducing patient waits of over 2 years, 18 months, and back to the 52 weeks and eventually the 18. We have some high pressure areas where waits are longer than others, and if you've got specifics, we can pick those issues up. But from a general perspective, there is weekly scrutiny on lists, and we will continue to work with mutual aid where we have gaps. And then it's a matter of creating as much capacity as we can through recruitment into our theatre teams in order that we can maximise our estate.
And I think it's probably good to mention that in terms of the national point of the question, we are working really closely with the National Elective Coordination Unit to review the waiting list and secure support outside our area where we can. And I know for urology actually was one of the ones that I saw when we were looking, where we secured it outside our area. And as Claire mentioned, not all patients want to do that, but we make it available for them. Thank you.
Thank you very much. There was one final question submitted online in advance. So, is it acceptable for patients awaiting biopsy results for potential endometrial cancer to wait an average of 19 weeks for the results? You did, no. Good. I think we can probably all agree that no, it's not. I think in your slide presentation, you talked about some of the challenges around diagnostics capability, and that is a strain that we're experiencing nationwide, but you can probably talk a little bit more about what's been done to rise and meet those challenges. Thank you.
Thank you. So we will get in touch with the individual because clearly they've got a pathway and they've been told 19 weeks. And colleagues in preparation to come here in that those waits are currently 20 days, an average of 20 days. So there's clearly been some change. We have had some very long waits as we've come through winter periods, and that's possibly where the worst case scenarios are in the 19 weeks. Pathology is a huge trade, and I am not a specialist at all. But our laboratories, as you can imagine, coming through the pandemic, manage a completely different workload to that which they did 3 years ago. So the COVID testing, that all that's still ongoing. And within our estate, there are samples that we send across Scotland. Some samples take many months and months to grow, and so some of those are on very long pathways. So we've outsourced some of our laboratory support because we have struggled with recruitment, no different from any other area. Pathology is in a similar sort of position to critical care and anaesthetics, as discussed earlier, that they are rare scientists. We're in the process of trying to recruit and close the gap ourselves. So in the immediate term, it's support from outsourcing, doing everything we can, maximising the laboratory estate that we have within Crosshouse and AIR. Outsourcing those areas on slightly longer development time so that our laboratories are dealing with the shorter turnaround times. And whilst turnaround times absolutely at their peak, I have no doubt that the individuals, there will have been something at that length, but the averages within gastroenterology routine is 40 days, urgent is 20 days, clearly longer than we would want, but significantly better than areas raised.
Okay, thank you very much. That's reassuring to hear, thank you. I'm going to open the questions to the floor now, and I would reiterate that it isn't appropriate to answer questions about patient-specific issues in public. Such matters will be taken forward with the board separately, but is there anyone who'd like to ask a question? Yes, go on.
Good afternoon. I'm Dr. Maxwell. I'm a GP in the South locality and also a patient with long-term conditions. The information given in the presentation about what was happening with outsourcing, looking at waiting list initiatives, etc., sounds very good, but it's transactional. Nothing is there dealing with the ongoing continuity of care of people with long-term conditions. The examples that are raised in the written question, diabetes and gastroenterology in AIR, are now virtually non-existent. Diabetes has been virtually non-existent for a significant number of years now. For patients in the Deep South, it is inaccessible to have to travel to Crosshouse for achieving consultations with a consultant. Some of our patients are elderly, struggle with hearing and sight, and struggle with use of technology, so telephone consultations, video consultations don't meet their needs and requirements. There needs to be something more local, something in AIR. I assume, maybe wrongly, but I assume when consultants are employed, they're employed with a contract to NHS Ayrshire and Arran. If that's the case, despite Crosshouse maybe being their main place of work, can they not be required to conduct outreach clinics at Ayr Hospital where there's gaps, or other areas where there's gaps? And equally, if recruitment is such a great difficulty, who is asking the question, why? Who is asking the question about what is NHS Ayrshire and Arran's reputation that people do not wish to apply to work here? There must be something. And unless you ask the question, unless you start to find out why people are not and what the reputation is, and certainly among junior doctors, I regularly hear, oh, I wouldn't do my GP training in Ayrshire, the hospital jobs are awful. And things of that nature is not acceptable without finding out why and what can be done to alter the reputation that Ayrshire has.
So I'll start and then I'll pass on to Claire, but certainly the junior doctor feedback that we've had this year, and we've just recently had the questionnaires completed, don't reflect what you've just said, but I take on board that it's really challenging, particularly in Ayr, where their staffing levels are not as great as they are in Crosshouse. In terms of endocrinology and diabetes in particular, we do also have a short life working group underway, looking at initiatives trying to reduce the demand, but also looking at how to use the wider clinical team to try and provide a better service. In terms of the contract issues, yes, I assume that we do offer Ayrshire and Arran contracts, but I'll let Claire talk to what we can or can't do in terms of specific outreach clinics, if you don't mind, Claire.
Yes, of course. Sorry, I was just quickly trying to write down the points. So, very happy to pick up a discussion with regards to your the feedback that you've had with regards to medical training, because as outlined by Leslie, our feedback is quite different in the last 5, if not more years. So our medical director is on the floor, and the new medical workforce, which was a substantial change, bringing in clinical fellows and changing the spectrum of specialty doctors, was a significant program of change. And before coming to this meeting, I was talking to the associate medical director for medicine, specifically around the diabetes, and he is working hard with the clinicians we have at Crosshouse about how we get an operating model that is a single team across both sites in order that a service is provided at Ayr. At the moment, there's just not enough of them to be able to cover the scale of Crosshouse and here, which is why we've got the hiatus that we've got. We have a very competitive market, and we are looking at specialty doctors and about how we attract a workforce to join a team in that dual site model. And so it is a constant challenge. So if in terms of contract, the contract for both sites is something that's absolutely coming in. A single site, 2 site single team, two-site model is very much where the contract is going. But if I could just defer to Crawford, who will be far more articulate about the specialty doctor regime, I would like to reassure you it's significantly different. And our GP placements and training placements, we haven't had any gaps. Yes, so, which is, and we can only talk for this period. So there might have been, there's always room for improvement, as we've said. But actually, our gaps in primary care have reduced significantly, and I think we're against a very competitive market in that acute sector. But if I could, Crawford, if there was something you'd like to add.
Al, thanks for that question. I'm Crawford McGuffey. I'm the Medical Director and Deputy Chief Executive. In 2018, we spotted what you pointed out there, that reputation is everything in terms of medical recruitment. We set ourselves the ambition to build the best medical workforce that supported the best training environment. And so the board invested in that, and we worked with NES in terms of trying to predict where our gaps might be. In 2018, we went from 25 clinical development fellows to 50, consolidated some of the more junior rotas in the hospitals, and it was a huge success. So into 19 now, we went from 50 to 75, and then the next year went from 75 to 100. We're now sitting at 126 fellows. We're the top recruiter in Scotland for clinical development fellows to consolidate those rotas that you're talking about. So best in class there. In terms of international medical recruitment, we saw that the pipelines were going to change, and there was going to be a much greater dependence on international medical graduates over the next 10 years. And that was reflected in NHS Education for Scotland information as well. And so this year, that's just the academic year that's just finished in August, we had 26 international medical graduates. That's jumped up to 46. We're best in the west of Scotland in terms of international medical graduates. We're doing all that we can at that junior level. I think that's part of your question. You know, why do people not come? Well, you need robust rotas. You need people to support you. You need people you can supervise and people you can train. So that work is ongoing and still challenging, despite my claims in terms of what we see in terms of the data. In terms of that single service, 2 sites in 2018, we realigned our medical management structures around about that single service, 2 sites. And the diabetes example has been played through. We now have a core of 4 consultants just now with an additional locum, where a board this size, in terms of benchmark, we'd hope to have 14. So we've got some work to do in that consultant area. But that's team fit, that's junior fit, it's around about other responsibilities. And I think it also plays into the pandemic in terms of how we do that. But we've got a single caseload in diabetes and endocrinology for the whole of Ayrshire. We're using all the available technology and digital means to shorten those travel distances to the board, and using Near Me, etc. And telephone consultations. So we're very aware of the things that you pointed out. We're in recovery post-pandemic, and we're in that constant undersupply of senior medical workforce, both in primary care and consultant workforce. So it's not easy. But I want to reassure you that we're sighted on these challenges, and where we have turned our attention, we're being successful. But I, like you, share that ambition for the whole of Ayrshire. Thanks.
Do we have any other questions from the floor? Everyone happy? Content. Well, improving, committed to improvement. Okay, so shall we? If there's no more questions from the floor, then I guess we'll just draw to a close a little early. This is a very unusual experience for me. Generally, when I chair, things run a bit late. Usually there's a bit more chat than this, so I'm grateful to finish on time. It's been really interesting and worthwhile to have this engagement. I can't say how lovely it is to actually be here in person and to hear, I mean, particularly those questions, to hear about how the national picture is replicated in each local area and the particular challenges that that brings to each local area. I want to thank everyone who's attended, everyone who contributed questions in advance of this meeting, and also thanks to everyone who's organised today's event. We'll summarise the key points from all of our engagements today, actually, in a letter in the coming weeks, and that will be published on the board's website. Thank you, everyone, for coming along. Thank you.